a hot day, 38 degrees Celsius temperature in Navi Mumbai. But today, I take privilege to welcome you all for 141st CAB of NMDF, that is Navi Mumbai Doctors Foundation. The today's topic for the day is medical management of stones. For this topic, we have a esteemed speaker, Dr. Jitendra Khandge. He is consultant nephrologist. He is having his own clinic at Vashi Sector 17 Shanti Center. He also visits Bhavna Hospital Nerul Sector 21. He is consultant nephrologist at Terna Multispeciality and Reliance Hospital Koperkerne. He has vast experience of almost 15 to 17 years in the field of nephrology. His clinical expertise is in main nephrology, clinical nephrology, transplantation including ABOI and cadaver. Critical, critical care nephrology also he looks after vascular access procedures. He has attended numerous national and international conferences. His research activities also are there. He has books also published. He's one of the interesting research has been in the case of idiopathic granulomatous interstitial nephritis. He has one interesting book which you all of you will like, that is the role of keto analogs and low protein diet in the retardation of chronic kidney disease. He is one of the authors along with Dr. L. Suratkai and Dr. H.R. Khandekar, and which is published by British Medical Journal. So talking about calculus, sir, we are seeing so many patients of calculus. Patients are interested till the diagnosis and then they just vanish. They just switch over to alternative pathy. But yes, definitely there is a standard protocol and medical management of kidney in allopathy. So we'd like to hear you. We just know there are 4 types of stone, all the oxalate stones, uric acid stone, cystine stone and struvite stone. Sir, without delay, I would request Dr. Jitendra Khandge sir to share his pearls of wisdom towards this topic. I welcome you all once again. Thank you.
Thank you very much, Dr. Sachin Korde, for this introduction. So we'll start with the presentation. Can we share the slides?
Just a minute, sir. Yes.
Yes. So today's topic is medical management of kidney stones. Next slide. So kidney stones is a frequently occurring condition. All of you must have seen plenty of cases till now. So this is entity is described in antiquity by many observers. It is a common problem affecting at least 1 in 11 individuals. It has been mentioned in Oath of Hippocrates. Over the last 150 years, the pattern has changed.
Excuse me, sir. Someone chat. Someone send message to chat that you increase your voice, please. Little louder.
Okay.
Yeah.
So stone diseases are likely to recur. At least 50% of the individuals have recurrence within first 10 years of the first occurrence. It is associated high incidence of individuals in patients with obesity, hypertension, and diabetes. And diet and lifestyle play an important role. Next slide. Next slide, please. So stones, according to their location, they have been described as nephrolithiasis, urolithiasis, ureterolithiasis, and cystolithiasis. Next. So various nutritional factors contribute to the stone formation, like calcium intake below significantly above the recommended dietary allowance, low fluid intake, high sodium intake, limited intake of the fruits and vegetables, and high intake of animal-derived fluids. Next. So evaluation, detailed medical history needs to be taken with medical comorbidities, medications that can cause stone disease. Then the dietary history, which includes the intake of fluids, amount and the specific beverages. Then protein intake, amounts and types. Then calcium, sodium, and oxalate containing foods, fruits and vegetables, and over the counter supplements. Then we need to evaluate the serum chemistries and the patient should undergo urine analysis. Next slide. So etiology, we have dietary factors which contribute. One is vitamin A deficiency, which can causes the disformation of endothelium, and cells form nidus, over which the stone is deposited. Then altered urinary solutes and solids. Dehydration increases the concentration of the solutes, and reduction of the urinary colloids, which absorb solutes, also with chelate calcium. So it may result in tendency to crystal and stone formation. So mainly the concentration of urine, the pH, and the volume. All these things matter. Next slide. Next slide, please. Yes. Then one more factor is decreased urinary citrate. Normally it is around 300 to 900 milligram in 24 hours sample. It tends to keep the relatively insoluble calcium phosphate and citrate in solution form. So decreased urinary citrate tend to cause stone formation. And then renal infections, Struvite stones, which are caused by the urea splitting Streptococcus and Proteus species. Then inadequate urinary drainage and urinary stasis. So, which stones are liable to be formed in patient in which the urine does not flow freely. Then prolonged immobilization also causes a skeletal decalcification and increase in the urinary calcium, which leads to stones.
Excuse me, sir, you have some disturbance in your voice, so please check if you are talking.
Okay.
Yeah.
Next slide, please.
Yes.
Yes, so hypercalciuria is one more condition. Idiopathic hypercalciuria, primary hyperparathyroidism, renal tubular acidosis, sarcoidosis, and vitamin D intoxication can cause hypercalciuria. Then hyperoxaluria, in which the primary hyperoxaluria, enteric hyperoxaluria, then toxic hyperoxaluria, then hyperuricosuriya, then problems with the urinary acidification and alkalinization. Next slide. So infections with urea splitting organisms. Urea is split to ammonia, which is hydrolyzed to ammonium hydroxide, raising the urinary pH to 8 to 9, in which the Struvite precipitates. And Struvite stones disease is also called stone cancer, and it tends to be very large, the organ calculus, and frequently result in renal damage. The patient may be relatively symptom-free until the stone occupies the whole collecting system. Next slide. Cystinuria, being an inborn error of metabolism, characterized by increased urinary excretion of cysteine, ornithine, lysine, and arginine due to defect in the renal absorption of the amino acids. Cysteine being insoluble, it precipitates in the concentrated urine. These stones are large, radiolucent, and recurrent. Some of the drugs, like triamcinolone, can also be metabolized to insoluble compounds and can precipitate in urine. Then acetazolamide also causes type 1 and type 2 renal tubular acidosis, which can cause nephrolithiasis. Next slide, please. So this is the frequency of various stones. The maximum being calcium stones, 70 to 80%. Calcium phosphorate is 5 to 10%. Oxalate or phosphate, 30 to 45%, and oxalate stones, 20 to 30%. Struvite stones are 15 to 20%. The cysteine stones being rare, 1 to 3%, and uric acid stones, 5 to 10%. So knowing the composition of the chemical composition of the stones is very important. Next slide, please. So these are the types of calculi. Oxalate calculi, which are irregular in shape, covered with sharp projections, which can cause bleeding, and the surface is discolored with altered blood. They are hard and radiodense. Next slide. Phosphate stones, these are smooth and dirty white, grow in alkaline urine, and enlarge to build most of the connecting system forming sternum calculus. And may present with hematuria, urinary tract infections, and renal failure. It is radio opaque, so it can be easily seen on the fluids. Next. Urate calculi. These are hard, smooth, and multiple, vary from yellow to reddish brown, and are multifaceted. They are radiolucent and appear IVP spelling defects. And it is confirmed by CT scan most of the times. Next
सर
slide.
एक्सक्यूज मी सर तुमचा आवाज काही कंप्लेंट्स अजून आहेत की आवाज क्लिअर येत नाही खूप डिस्टर्बन्स आहे काय करू शकतो सर आपण पटकन
Disturbance actually लॅपटॉपचा जो बॅकग्राऊंड आहे तोच आहे.
हो तो तुम्ही एअरफोन वापरू शकता का
सॉरी
एअरफोन वापरू शकता का तुम्ही
हेडफोन का
हा
I request all the participants to put their questions in chat box. So we will take one by one and there will be smooth conduction of the session. I request to put questions in the chat box. Thank you.
आता ऐकू येते का
हा आता थोडंसं बरं येते लिटिल बेटर so please go ahead please
okay so uric acid calculi they are hard
इको येतं इको ऐकायला येतो थोडंसं तुम्ही दोन ठिकाणी करत असाल तर एका दुसरा बंद करा आवाज इफ यू आय थिंक यू आर लॉगिंग फ्रॉम टू वेज ना सर
आता
yes better it is better
okay now you can hear
yes sir please go ahead
okay so they are hard smooth and multiple vary from yellow reddish brown and are multifaceted they are radiolucent and appear on IVP as filling defects and the presence is confirmed by the CT scan next slide please so cystine calculus these are associated with the congenital errors of metabolism which cause cystinuria they are hexagonal translucent and white crystals of cystine appear in the acidic urine. There are multiple may grow to form a cast of the collecting system. Pink or yellow when first removed. They change to greenish color when exposed to air. And they are radio opaque because they contain sulfur and are very hard. Next slide, please. Xanthine calculi, these are extremely rare, smooth and round, brick red in color, and show lamellations on cross section. Next slide, please. So clinical features, the stones can be just asymptomatic. Mostly the kidney stones are asymptomatic. Then some of them are associated with urinary tract infections, and some of them may have uremia as the first indication of stones. Next slide. So pain is the most common symptom. 75% of the patients. Then loin pain relating to groin is the book described presentation, and it may be worse on movement, and particularly on climbing stairs. Then ureteric colic, it is agonizing pain passing from the loin to groin, and it starts suddenly causing the patient to find comfort. The pain resulting from the renal stones rarely lasts more than 8 hours. Any problem?
No, sir. Go ahead, please.
Okay. So there is no fever. The severity of the colic is not related to the size of the stone. Next slide. Hello. So the next presentation is hematuria, sometimes leading symptom of the stone disease. As a rule, the amount of bleeding is small. Then the next presentation is pyuria. Infection is dangerous when the kidneys are obstructed. Pressure builds in the dilated collecting system. The organisms are injected into the circulation, and septic shock can occur. And the mechanical effect of the stones irritating the urothelium can cause pyuria, even in the absence of infections. Next slide, please. Investigations. Next slide. So in the imaging, we do the X-ray, plain abdominal X-ray, then IVP, spiral CT scan, and cystoscopy. So multiple or bilateral renal calculi get a risk of recurrence. And nephrocalcinosis, which shows the underlying metabolic disorders like primary hyperthyroidism and RTA. Then anatomical conditions like medullary sponge kidney predisposing to stone formation. Next slide. So radiography, KUB shows the kidney, ureters, and bladder, and the differential diagnosis are like calcified nodes, gallstones, foreign bodies in the alimentary canal, phlebolytics, etc. Next slide, please. Next slide, please. Yeah. So this is the X-ray showing the Stagon calculus. Next slide. So IVP, it is the procedure used to visualize the abnormalities of the urinary system. And next slide, please. So the dye is injected and an X-ray is taken. So it shows the kidney, ureter, bladder, and the opacities can be seen as a filling defect, and which can locate the stones. Next slide. So this is how the dye passes, and we can locate the stones according to the location of the filling defect. Next slide. So it can be an emergency procedure or a routine procedure. For emergency, in patients with severe colic and positive hematuria test, then patients with no obstruction but positive stones, and discharge with follow-up with appointment and with the urologist. And the patients with kidney stones and obstructions are usually required to stay in the hospital for monitoring or further treatment. Next slide. So some of the contraindications. ARF and CRF are contraindications. Allergy to the contrast is a contraindication. Metformin should be stopped 48 hours pre and post procedure. Next. So contrast enhanced CT scan is the mainstay of investigation. Then ultrasound is the routine test done for locating the stones, but we have to rely on the CT scan abdomen to for exact location of the stone. Next slide, please. So now ureteric calculi. So the clinical features remain the same. The ureteric colic is the main symptom. So intermittent attacks of colic and strangury, the painful passage of the few drops of urine, which typically occurs in the stone in the intramural part of the urethra. Next slide. Haematuria, which occurs in almost all the cases as either microscopic or macroscopic hematuria. Next slide. So pain, as the stone becomes impacted, there are attacks of colic, and it can be increased by exercise and lessened by rest. And the severe renal pain subsiding after a day or so suggests that complete ureteric obstruction. And if it persists after 1 to 2 weeks, it should be removed because the prolonged distension of the kidneys will eventually lead to atrophy of the renal parenchyma. Next slide. So 5 sites of narrowing. One is at the ureteropelvic junction. One is at the crossing of the iliac artery. Third is a juxtaposition of vas deferens or a broad ligament. Then entering the bladder wall. And fifth is the ureteric orifice. Next slide. On abdominal examination, we find tenderness and rigidity over some part of the course of the ureter. So we have to, presence of hematuria does not rule out appendicitis. So on the right side, we have to be careful about the examination because appendix can also have similar presentation. Like next slide. So serum chemistries, electrolytes, calcium, creatinine, uric acid. Then the urine analysis, routine and microscopy, which shows the urinary pH and some indicators of infection like nitrates positive can indicate infection. Then the crystals pathognomonic of the stone type. Then urinary culture, urine culture in patients with urinary tract infections. Then serum intact parathyroid hormone in suspected primary hyperparathyroidism. And in case we are able to get the stone, we should do the stone analysis to find out the type of the stone. Next slide. Additional screening, metabolic screening is required in high risk and patients and recurrent stone formers. And 24 hours urine sample is taken and which is tested for the volume, pH, calcium oxalate, uric acid, citrate levels, then sodium, potassium, and creatinine. Then urinary cystine levels, urinary oxalate levels are done in patients with high risk stone formers and recurrent stone formers. Next slide. So the conservative management, the medical management, the mainstay is forced increase in the fluid intake to achieve the daily urine output of 2.5 liters. So studies have shown that at least urine output of 2.5 liters is required to have the stones out of the urinary system. Increased urine output has 2 effects. One is mechanical diuresis. Second is the dilute urine alters the supersaturation of the stone components. The next therapies are the dietary therapies and pharmacological therapies. So dietary therapies. So the fluid intake to achieve the urine volume of around 2.5 liters. Then alcoholic beverages and coffee, tea, wine, orange juice are associated with low risk of stone formation. Then sugar sweetened beverages associated with increased risk. Then ample fruits and vegetables to counterbalance the foods that confer an acid load. Next slide. So we'll speak about the specific stones. If we have a stone analysis and if we found it as calcium stone with relatively high urinary calcium, we should limit the sodium intake. Then 1 to 1.2 milligram per day of dietary calcium, and supplementary calcium in contrast may be associated with an increased risk of stone formation. Next slide. In case of oxalates with relatively high urinary oxalate, we should limit the oxalate foods, and we should consider the normal calcium intake during the meals, that is 1 to 2 grams daily. In case of enteric hyperoxaluria, that is in cases with inflammatory bowel disease or ONY gastric bypass, we should restrict the oxalate diets. Then higher calcium intakes, which should be timed with meals, and restricts the vitamin C and other over-the-counter nutrition supplements. Next slide. Calcium stones with low urinary citrate. We should increase the intake of fruits and vegetables, limit the non-dairy animal proteins, and dietary alkali citrate as an alternative to the pharmacological citrates. Then the conditions which can cause hypocytaturia is metabolic acidosis, RTA, chronic diarrhea, and medications like carbonic anhydrase inhibitors. So we should treat these conditions accordingly. Next slide. In the case of uric acid stones or calcium stones and relatively high urinary uric acid, we should limit the intake of non-dairy animal proteins, as the uric acid crystal formation and growth occur in the more acidic urine. Then increase alkali load and decrease acid load of the diet in an effort to increase the urinary pH and reduce the urinary acidity, which prevent and decrease the size of the uric acid stones. Next slide. Cystine stones, the dietary therapy and in combination with pharmacological therapy is useful. We should ensure a high fluid intake, oral intake of at least 4 liters to decrease the urinary cystine concentration below 250 milligram per liter. Then dietary sodium restriction to 100 ml equivalent or less per day, that is 2 to 3 grams. Then limiting the animal protein intake to decrease the cystine substrate load. Next slide. Pharmacologic therapies. So various drugs are used in case of stones. First and foremost is thiazide diuretics in patients with high and relatively high urinary and recurrent calcium stones. So the thiazide dosages associated with the hypocalciuric effects: hydrochlorothiazide 25 milligram twice a day, 50 milligram orally once a day. Then chlorthalidone 25 milligram orally once a day, and indapamide 2.5 milligram once a day. Potassium supplement is required mostly in the form of potassium citrate. In case of we can instead of potassium supplementation, we can also use amiloride or spironolactone. And triamterene should be avoided because it itself can cause precipitation, stone formation. Next slide, please. So recurrent calcium stones, potassium citrate therapy should be used, and it can be used in case of recurrent calcium stones and lower normal urinary citrate. It can also be used in the calcium phosphate stone formers with hypocytraturia, and along with that, thiazides can also be used to lower the urinary calcium excretion. In some cases, with allopurinol can be used with recurrent calcium oxalate stones with hyperuricosuriia and normal urinary calcium. Next slide. So first line therapy is using potassium citrate, and there is no need of using allopurinol as a first line therapy in patients with uric acid stones, as mostly the main pathological event occurring is the low urinary pH rather than the high uric acid levels. Next slide, please. So tioprotein can be used in patients with cystine stones, which are unresponsive to the dietary modifications, urinary alkalinization, or have large recurrent stone burdens. It is possibly more effective and associated with fewer adverse events than D-penicillamine and should be considered first. Next slide. Then acetohydroxamic acid in patients with residual and recurrent Struvite stones only after surgical options have been exhausted. This compound has a lot of side effects, so it should not be used routinely because the side effect profile may be more than the usefulness of the drug. So Struvite stones occurring as a consequence of urinary infection with urease producing organisms. So patients treated with for Struvite stones may be at risk of recurrent UTI after stone removal and can cause septic shock. And in some cases, the surgical stone removal may not be feasible. These patients are at increased risk of recurrence and progression of the stone. Next slide. Follow. So after the medical management and the surgical management, we need to follow these patients up for various reasons. So first thing is to see assess the response to the dietary and the medical therapy. Then at first follow 24 hours urine specimen, which has to be checked annually or with greater frequency, depending upon the stone activity, and to assess the patient adherence and the metabolic response. And this monitoring mainly allows for the assessment of the patient adherence, identification of the patients refractory to treatment, and timely adjustment in the therapy for individuals with active stone formation. Next slide. Follow-up investigations. Long-term monitoring for reinfection with urease producing organisms, and periodic urine culture needs to be done. Repeat stone analysis in patients with non-responders, and periodic blood testing to monitor the side effects of the medical management pharmacological therapy. Like thiazides may cause hypokalemia or glucose intolerance. Allopurinol and thioprotein can cause elevation of the liver enzymes. AHA and thioprotein can cause anemia and other hematological abnormalities. And the potassium citrate can cause hyperkalemia. Next slide, please. Other imaging studies for follow-up, plain abdominal X-ray. It is readily available, associated with limited radiation exposure, lower cost, and acceptable assessment of the stone activity in case of radiopaque stones. Sonography, it is useful in the radiolucent stones, and there is no exposure to the radiation, and it is less costly as compared to the CT scan. Next slide. So low dose computed tomography, most sensitive way to detect the stone activity, defined as either the existing stone growth or new stone formation. 1 year imaging interval is recommended for stable patients, depending upon the stone activity and signs, clinical signs. Next slide. So primary care practitioners, all of you can do this, and the physician extenders are experts at counseling the weight loss, exercise, and smoking cessation, and the dietary precautions also. Implementation of stone prevention regimens could also be extended to the emergency rooms and primary care offices. So that's how I conclude my presentation on medical management. I'm ready to take the questions.
So you can see some chat questions, chat box questions. Please go ahead.
Dr. Khandge, sir.
Generally, how many?
Yes.
Sorry. Generally, how many millimeters of stone is passed out?
Hello.
Yes, sir.
Can you hear?
Yes, sir.
Yeah. Any questions?
Stone passed out.
Hello.
How many millimeters of stone is generally passed out?
Usually up to 8 millimeter stones can pass out. At times, in some exceptional cases, up to 10 millimeters and even 1.12 millimeters stone has also passed, but it is a exception rather than a
Tamsulosin helps in helping the stone to pass.
Sorry.
Tamsulosin tablet helps in passing the stone.
Which tablet?
Tamsulosin.
Protein.
Tamsulosin, sir.
Tamsulosin, yes. Tamsulosin can help to ease out the passage of stone. Tamsulosin Silodose that for relieving the spasms, Struvite is frequently used. So during the passage of the stone along the ureter, there can be irritation of the inner wall of the ureter causing spasms. Those can be relieved. The stone can come out easily. Most of the times, it may be associated with microscopic hematuria. And we should ask the patient to increase the fluid intake. Then we should give potassium citrate along with it. And treatment like rotavirin can be given, and silodocin or tamsulosin.
Sir, doctors are asking, what do you mean by non-dairy protein, animal proteins?
That is like meat, chicken.
Yes.
Which is the best drug to relieve colic?
Colic can be antipsychotics can be used. I use rotavirin in the double dose injections.
Sorry, sir, can't hear.
Rotavirin.
That relieves the pain.
That relieve the spasm and decrease the pain significantly. You can use. You can use SADs to relieve the pain with the patient, because the immediate relief will be given by the painkillers. I usually use high dose of paracetamol or tramadol, tapentadol for these patients.
And for vomiting?
Vomiting, we can use etc. And if you are taking on the OPD basis, you can use domperidone along with antacid like pantoprazole or rabeprazole.
Sir, doctors are asking, thiazide group, can you repeat the dosage and how long it can be taken as a diuretic agent?
So it is hydrochlorothiazide, 25 milligram twice or 50 milligram once a day. Indapamide 2.5 milligram per day, or Thaladone 25 milligram orally per day, once a day.
So one of the doctors are asking why metformin is should be stopped before the procedure of IVP. What exactly it does?
Metformin tends to cause lactic acidosis.
We have Dr. S.V. Kulkarni. Dr. S.V. Kulkarni, sir, please unmute yourself and you can ask your question.
Yes, Dr. Jitendra, I will request you to elaborate some of the emergencies which are associated with stone-related disease, especially in patients with diabetes. Because this is one condition which, if the family practitioner recognizes at a very early stage, or even if he knows it and if he has got some idea about this situation, how you will expect them to react and how to proceed with the patient. A diabetic patient, middle-aged diabetic female who has got history of renal calculus, and she is coming with a very severe pain as well as high-grade fever, USG showing abnormal, but you are suspecting something different, which is going to be drained with just one digestate. Please explain the situation.
Yeah. One thing, we can have emphysematous pyelonephritis in a diabetic patient with infections and digestant. You will have an obstructed system along with the anaerobic infection. And high dose of antibiotics, long dose, like duration for 3 weeks. That can, and in some cases, nephrectomy can also be required in case of emphysematous pyelonephritis.
Sir, how long sildocin, tamsulosin medicine should be continued? Is it safe and how much duration?
Usually, week-long course of the medicine is useful. If the patient is not getting the stone relief, the pain relief, we should not wait more than that. We should have imaging, CT scan, locate the stone, assess the size of the stone. And then if it is more centimeters, we need to go ahead with the surgical procedure and waiting for medical management.
Dr. Rathod, will you unmute yourself and ask your question? Dr. Rathod?
Sorry, it was by mistake. I raised my hand,
Okay,
sir.
fine. Sir, commonly patients are asking, can we take beer? Beer can pass our stone very easily. Is it advisable to increase the intake of beer, like beverages?
No. Better not to rely on these afwas.
Yes. Sir, generally we see the prescriptions, potassium citrate, that bottles, urilizer. These bottles can be consumed for long time, long duration, 6 months, 1 year.
Yes.
So,
This bottles come in the size of 250 ml also. And some patients with a recurrent stone forms, we can continue the alkalinization therapy for maybe 6 months or 1 year. Because many of the patients who are recurrent for stone formers cannot change their habits also. Plus, they tend to have recurrence. One way of doing it is continue the potassium citrate for a year long, so that the alkalinization is continued.
So one of the doctors is asking,
size at times. Yes.
One of the doctors is asking, known calculus patient, can he take calcium supplements, or he should restrict himself for taking?
The amount I mentioned is 1 to 1.2 grams per day. Normal calcium intake can be continued. We should not go ahead over and above that, because we need not, in case of calcium stones also, we should not restrict the calcium, because the main culprit is sodium. We have to restrict sodium. The restriction of sodium will indirectly improve the stone structure and other thing. So we need to continue with the normal calcium diet. But taking supplementations over and above the RD is not recommended, because high dose of calcium can also cause stone.
So in case of hydronephrosis, does a high amount of intravenous fluid will help to expel the stones?
It can cause, like I had described, it can cause diuresis, and it will try to push the stone to the lower level. But at times, if the stone size is more than 8 millimeter, it will be impacted in the ureter, and then we have to intervene.
Thank you.
Sir, one of the slides you mentioned the word nephrocalcinosis. Can you highlight again about it? Nephrocalcinosis.
Into the renal tissue. So it is part of type 2 renal tubular acidosis. So along with other conditions. So if we treat the type 2 RTA, the nephrocalcinosis can improve. But at times the nephrocalcinosis can remain silent without any consequences. At times, over a period of time, it can progress to chronic kidney disease.
So does this stones runs in families? We've seen plenty of patients in one family. We see sometimes.
As we have seen, there are some inherent metabolism disorders like cystinuria. Then, so all those conditions which I mentioned, those can run in families. So it is possible that we have a certain type of stones which can be present in all the family members, and they should first have a stone analysis If the stone analysis, according to that, we can have the therapies given to that patient and the family. And we should have a follow-up studies, as I have already mentioned in the presentation, so that we have a progression of the disease or formation of new stones can all be picked up at the earliest.
So which condition we should go for surgical interventions?
Like if the medical management is not working for more than a week or so, then there is no point in just continuing with the medical management, because it will have back pressure changes on kidney parenchyma and the epithelia. So we should not continue with the medical management more than maybe a week. And second thing, stones. If we have documented evidence of stones more than 8 millimeter and persistent symptoms not relieved by the medical treatment, go ahead with the surgical intervention.
So what is the cost of stone analysis?
Stone analysis in Metropolis, I think it is around 1200. 1200 to 1500. So once we have stone analysis, then ask them for dietary modifications, as I have mentioned. Then second thing, any specific pharmacological therapy can be given. Most of the times the problem is there is stone analysis done. Even after the surgical intervention, those stones are not analyzed. So we cannot have a proper dietary advice to the patient and pharmacological therapy to offer to the patient.
Dr. Meenakshi Kure madam is asking, can stone pass unknowingly without pain? Can person observe in bathroom that a stone is passed without pain or anything?
Many times it has happened. If the small stones like 2, 3, 4 millimeter stones, you can pass. But most of the times there will be some discomfort in the lower ureter because it is the narrowest portion of the ureter. It is less likely. The patient may not have noticed, but it is possible.
So, anybody has to ask any questions now? Because
yes, yes, Dr. Sachin, बहुत ही सिली क्वेश्चन है डॉक्टर जितेंद्र. बहुत सारे पेशेंट बोलते हैं कि पालक और ये जो जितने भी जैसे टमाटर होता है या कोई भी बीज वाले फ्रूट्स या वेजिटेबल्स होते हैं उनको खाने से स्टोन होता है. क्या ये एक मिथ है? क्या मतलब इसका क्या सिग्निफिकेंस है?
Oxalate, they are high in oxalate. So they should be avoided.
मतलब जैसे मान लीजिए पर डे अगर कोई एक टमाटर खाता है या जो दाल और सब्जी में हम डालते हैं उससे भी हो सकता है. मतलब इतना भी नहीं खा सकते पेशेंट्स?
नहीं, उतना तो the quantity is okay, but the thing is if the patient are recurrent stone formers, we should completely avoid.
Okay.
Yes, they are high in oxalates, the chocolates and other things.
Okay, thank you.
Patient gets urinary tract home. Hello.
Yes.
Stone gets a urinary tract infection. Generally, is it a E. coli infection or something else may be there?
It may be associated with gram-negative organisms. The only stones we are concerned about is the which I mentioned in the presentation, because the stones associated with those are recurrent and but other species can also cause.
So in short, I just summarize in the loin as well, but the important hematuria and pyuria can be one of the symptoms even in the absence of urine infection. Just pyuria, hematuria also a sign of renal stones. And the doctor has precisely showed the sites of impacted stones where they can be impacted. And the very nice answer we should give to all the patients: how much water I should drink. Rather, we should tell you should pass 2.5 liters urine every day. That much amount of water you should take. And as the treatment mainly lies is that stone analysis will give exactly content of the stone, and then dietary modification is going to help us. We have often seen patients coming from the surgery after surgery, and they are not advised about surgical intervention. So we should advise about the diet, and the mainly animal diet, animal proteins, everything has to be looked for. And last important, patient once goes, we should tell him that yearly and USG ultrasound is very important for stable patient. And the new word we learned as stone activity. We should keep monitoring the stone activity. Thank you so much, Dr. Jitendra Khandge sir, to shower us with the wisdom pearls of yours, and will be like to be connected with you in future also. I thank you all my seniors, Dr. S.V. Kulkarni sir, Dr. Godse sir, Dr. Arun Pure sir, and all advisory members, and all the delegates who have attended this Zoom meeting. I thank